Well, it's a pleasure to be here. My name is Dr. Bauer, and I am from Advanced Screening. And actually, this is a seminar. We are going to be doing a screening here on April the 2nd. So it's a pleasure to be here. I wanted to talk a little bit today about the screenings we're doing, why they're important, talk about strokes and some of the other diseases that we're going to be screening for, and certainly answer any questions that you might have. Advanced Screening is the largest screening company in Michigan. We are Michigan-based. We've done well over 100,000 screens in the last 7 years or so. Our technicians are registered. We have a partnership with General Electric with their health system, so we collaborate with GE. One advantage that we have is that we are able to provide you with immediate results on site. So when we come and do your screening, we're going to be able to tell you right then and there what your carotid artery looks like, what your aorta looks like, and some of the other screening organizations, it's 2 to 3 week lag time. We like to be able to tell people right then and there what their results are. We provide a pretty extensive educational program. We do these seminars from time to time. We also provide at the site, we're going to tell you exactly what we're screening for. We have some literature that we're going to be giving you. So we firmly believe in the importance of the education component of what we're doing. We want you to know what the heck is going on, what we're screening for, and exactly what the screen is about. So we think education is pretty important. I'm a board-certified emergency physician is how I started out. I've had 22 years of medical experience. In my emergency medicine career, I've seen all of these diseases. I've seen strokes, certainly heart attacks, and people that walk in and have them right in front of me. So I'm in the front lines when it involves these disease processes, so I see the results of these as well. So it's really a pleasure to be able to provide some preventative avenues for people to prevent these things. I've had vascular training. I'm also an osteoporosis specialist, and currently I'm sitting on the Michigan Osteoporosis Leadership Council. So why is screening important? Why do we offer these services, and why should you be screened? The first thing is, the most important thing, is that these diseases can be prevented. Believe it or not, heart attacks, strokes, hip fractures, all of these things can be prevented if we catch them early enough. The other thing about screening is that Medicare and a lot of the other insurance companies will not pay for these screens, so that if you do not have symptoms, you cannot just go to your doctor and say, you know, Dr. Jones, I want to have a carotid artery test done. Dr. Jones says, well, I can't really order that for you unless you have symptoms. And a lot of times, by the time you have symptoms, things have progressed. So the whole philosophy of screening, we think, is important. Unfortunately, the insurance companies have not gone into that arena as yet. And a lot of the physicians, unfortunately, will not be willing to order these things. The other thing about screening is, with these particular diseases, prevention is definitely the best modality. If you talk about trying from an epidemiological standpoint, trying to prevent people from getting sore throats, the cost and the impracticality of doing that prohibits that kind of approach. However, with strokes and heart attacks, prevention is definitely the best modality. None of us want to be a stroke survivor. You know, most of us will get a sore throat and you survive having a sore throat. So preventing a sore throat is not something that is nearly as important. So prevention with these diseases is important. All this stuff is based on science. There was a landmark study by the AVA, the American Vascular Association, that was done recently. That was done within the last 3 years. They had 130 major medical centers involved in this study across essentially the whole United States. And 7.5% of the participants had a pretty significant blockage of over 50%. And they estimate at least 30 people from having strokes. And they laid out essentially a protocol for how to go about doing this screening, and that's essentially what we follow. It's also endorsed by the Society for Vascular Ultrasound. So we base all of what we do essentially on evidence-based medicine. Another real important reason why, from a cost standpoint, why screening is important is because of the cost of some of these problems. One stroke, the estimated cost from epidemiological studies, is about $147,000. So if we essentially screen all the people that were at risk, we have the potential of saving up to $13 billion across the United States. Hip fractures, the costs are about $38,000 to $40,000. You can see here about $4 billion of savings if we were to screen all of the people across the country who are at risk. Okay, so one of the main things that we screen for, and hopefully you will be undergoing this screening when we come back, is screening for stroke. Stroke is the leading cause of disability in this country. It's the third leading cause of death behind cancer and heart attacks. 700,000 every single year in this country, 700,000 strokes. And as you can see here, as you get older, the risk increases dramatically. So every 10 years after the age of 55, your risk for having a stroke is going to double. Cost of strokes every year is about $53 billion or so. And you can see here, it's responsible for half of all nursing home admissions. So tremendous significance. What are the risk factors for stroke? Well, there are what's called non-modifiable risk factors. Essentially, we're born with these things. We're all going to age, and as I said, as you get older, your risk is going to double for every 10 years after the age of 55. Men will have a higher incidence of stroke before 65. So that 40 to 65-year-old age group, especially for men, is very important. African Americans do have a higher incidence, more so than Asians and Caucasians. And this is probably the biggest one here. You had mentioned you had some family history. Any of you that have family history, that's probably the single most important. It holds true for heart attacks, holds true for osteoporosis. So family history is one of the key risk factors. Okay. Modifiable risk factors are the things that we can change. So these are the things that we are going to focus on. Once we do your screening, if we find an issue, then we can start dealing with some of the causes for the stroke. High blood pressure, you can see here, these are the relative risks of you having a stroke if you have any of these entities. Carotid stenosis, or blockage of the carotid arteries, doubles your risk. Atrial fibrillation, which I'm going to talk a little bit about. If you have an irregular heartbeat, you have atrial fibrillation, it more than triples your risk of having a stroke, and I'll show you a little bit why that is. And then the other things that we all know of, diabetes and smoking, high cholesterol, all of these things essentially are the main things that are going to increase your risk for stroke. Now, if we look at the immediate causes of stroke, what are the three things that will cause a stroke immediately? Essentially, the topical things that are going to cause a stroke at the time of the stroke. And the three main things are this: carotid artery plaque, which we check for, atrial fibrillation, which we check for, and hypertension, which we will also screen for. These are the three main immediate causes of stroke. If you don't have any of these entities, your chance of having a stroke in the next 12 to 24 months are fairly low. So, what kinds of stroke are there? There are two main kinds of stroke. One's called an ischemic stroke, which means there's a blockage, the brain cells are not getting enough oxygen, that leads to cell death, and you essentially have a stroke. And then you have a hemorrhagic or a bleeding stroke, which counts for about 15% of strokes. So those are the two main categories of stroke. Hemorrhagic strokes typically will happen due to high blood pressure, diabetes. It causes a break in the artery in the vessel of the brain, and then you have bleeding. And unfortunately, these can be catastrophic. People can die immediately of these. The other major kind of stroke that we see the most is an ischemic stroke, and there are two varieties of that. One is called a thrombotic stroke, and that's essentially from gradual buildup of plaque, gradual blockage of the artery. And then there's embolic stroke, when you have a small little piece of clot or debris, and then that travels to the smaller vessels, and that causes the occlusion. Typically, those will be from the heart, from atrial fibrillation, as I mentioned, or from another blood vessel like the carotid artery. So those are the two main kinds. Thrombotic stroke, you can see here, this is a normal-looking carotid artery as it branches into the external and the internal carotid. You can see here that the plaque is built up. It's this yellow material within the wall. And eventually what can happen is you can form a clot inside of the artery that essentially will occlude flow to the brain. And subsequently the brain tissue dies and you end up with a stroke. This is a thrombotic stroke where essentially there's blockage and that leads to the death of the cells. The next major kind of ischemic stroke is embolic stroke. And what that means is, and typically it'll come from the heart, you get blood clots, small little clots that form in the atrium of the heart, and essentially they travel up through the internal carotid artery and they lodge in a blood vessel, cause death of the brain tissue. Now that's one source. The other source of small emboli or clots is from the artery itself. So you get a little tiny piece of the clot that breaks off, travels to the brain, and then that causes a stroke. This is very common. Both of these mechanisms are very common. As I mentioned with bleeding or hemorrhagic stroke, a small little break in the blood vessel wall occurs, typically from high blood pressure. When you have diabetes, the plaque will form hardening of the artery, and so it doesn't bend as well with every beat of the heart and increased pressure, and so it breaks, and so you get this bleeding, and again that can be catastrophic. Blood leaks out and causes damage. Blood inside the brain is bad. It damages the tissue and causes increased pressure and so forth. So how do we go about looking for these problems that will lead to a stroke? Well, the first thing we do is we look for blockage in your carotid artery. Again, that's one of the three immediate causes of stroke. And we use Doppler ultrasound. Doppler is a way of recognizing flow characteristics of a fluid. And when we use Doppler ultrasound, we are able to tell if there's any change in the velocity of the blood going through the blood vessel. And actually what happens, as there is narrowing of the artery, the velocity, do you think it will decrease or increase? Increase, exactly. Think about this. Think about this visual. What did you do when you were a child to squirt off the car? You stick your thumb over the end of the hose, right? And it squirts out. The velocity increases. That's flow characteristics of a liquid. So we actually check the velocity via Doppler technique inside of that artery. If your velocity is increased, then that's cause for concern. That's usually secondary to the plaque. And we can actually see the plaque. It's when it causes a velocity change, then we know that the flow has been altered, and that's significant. The test is very quick. We can do a carotid screen ultrasound in less than 5 minutes. We are checking essentially this main area right here. If you were to go to a hospital and have a carotid study done, they will check the entire artery. More than 90% of strokes will occur due to pathology in that area. So that's why screens are typically focused in that area. Very high yield, very efficient, greater than 90% accuracy, and it's very inexpensive. If you were to have one of these tests in a hospital, diagnostic center, we're talking $300, $400, $500. Okay. How else do we look for stroke? We also look for something called atrial fibrillation, which is an irregular heartbeat. It's one of the more common heart arrhythmias. And what happens is you have extra foci of electrical activity in the atrium of the heart, which is where the heartbeat starts. And that causes the atrium, instead of beating consistently and pushing the blood out, it causes it to what we call fibrillate. And because it's fibrillating, there's not a lot of contraction. And so what can happen is the blood can stagnate, and when blood stagnates, it forms little tiny clots. And so little tiny clots will form here. They travel up through the carotid artery and lodge in the brain and cause a stroke. Again, one of the three immediate causes for stroke. So how do we look for this? Well, it's pretty simple. We do an EKG. If you are in atrial fibrillation, we will detect it by a simple EKG. Put electrodes on your chest, and this is what it looks like. These are what's called fibrillatory waves, these little blips here, and causes the clots to form, and this is one of the main things that we look for, because that can be treated. We can put you on medicine, and we can essentially prevent a stroke if we know you have it. Again, EKGs are very inexpensive. So how do we prevent a stroke from happening? First of all, we got to find out if you got blockage in your carotid artery. Okay. What do we do? Let's say you have blockage or you have family history. We want to prevent you from having a stroke. Well, it's the simple things. I mean, you're going to see this about 4 or 5 other slides here. Modify your diet, decrease fat in your diet, try and decrease your weight, exercise, stop smoking. I mean, these are all the simple things. Unfortunately, they're sometimes the hardest things for people to do, but these are probably the most effective. A lot of studies have shown if you adhere to some regimens that decrease your cholesterol, decrease your blood pressure, stop smoking, your risk for stroke is going to drop dramatically. So this is the first thing probably your doctor will tell you to do. It's the first thing when I do consultations with people that I tell them to do. We've got to try and get you on a regimen. Especially, we see sometimes 38, 40-year-old people that have beginning plaque in their carotid artery. Granted, it's only a small amount of plaque, but that to me is a red flag because they're pretty young and they're already showing that they are producing plaque. So to me, that's kind of a red flag that I try and push them to go through some of these measures. The other thing we can do is put you on something called Plavix. Have you ever heard of Plavix? Okay. Very effective drug. It prevents platelets from sticking together. And if you remember from one of those other slides, clots are one of the things that will cause an actual stroke. So this is an agent that will help prevent clot formation. And then these are further down the line. We can actually do surgery where a surgeon will go in, open up the artery, and actually clean it out. Again, that's further down the line. That's typically if you've got 70 to 80% blockage of your carotid artery. And then this is relatively new. You've probably heard of stenting of coronary arteries. People go in and have a heart stent. We're doing it now with carotid arteries also. So it's a way of opening up the carotid artery and preventing blockage on that basis. This is what the endarterectomy looks like. Again, make an incision. Essentially, I mean, it's not a pretty procedure if you've ever seen this. They essentially just go in and clean it all out. And plaque is not pretty. You open up a blood vessel or you open up an aorta, you'll see plaque, and it literally looks like yellow hamburger coating the walls of the artery. So it's not pretty, but they can clean it up pretty well. This is a stent here being put into the carotid artery, and you can see here to prevent little bits of debris when they put that stent in, there's a little filter that catches some of the debris as they're putting in the stent. Okay. What else can we do? Well, if you have atrial fibrillation, we've got to do something about it. The things that will help prevent atrial fibrillation, again, the same stuff with lowering your fat in your diet, exercising, that kind of thing. But we would definitely put you on some medicine to prevent clot formation. Most of the time, if you have atrial fibrillation, unless you have a contraindication to it, you will go on what's called Coumadin. Which thins your blood, essentially, and prevents those little clots from forming so they don't travel to your brain and have a stroke. So most of the time you will go on Coumadin if you have atrial fibrillation. Okay, and then again, the third immediate cause of stroke is high blood pressure. So all the same stuff to try and get your blood pressure down, and then ultimately we need to put you on drugs if the blood pressure does not change with modifying your diet and exercise. And this is what happens with hypertension. The increased pressure in the vessel wall will cause plaque formation. It will also cause some thickening of the muscular layer of the artery because the artery is trying to contain that increased pressure, so it responds by thickening its muscle. And this is what we see with hypertension. Very, very important disease. It is simple. I shouldn't say simple, but it's relatively easy fix. It just takes a little bit of determination on your part and your physician's part. Okay, So now we're moving into peripheral vascular disease, which is another thing that we look for. A real important reason why we look for blockage in your legs is because there's a high correlation of blockage in your peripheral arteries with coronary artery disease. Very strong correlation. So if we do a test and we know you got some blockages in your legs, there's a real good chance that you've got significant coronary artery disease. And peripheral arterial disease essentially involves the legs. Occasionally we'll see it in the arms, but typically it involves the legs, and that's where we screen for. The symptoms of this blockage essentially are pain with walking is the main symptom. It's called claudication, where you walk, you're not having any pain, and then you walk maybe 200 feet and you start having pain in your legs. And then you sit down and you rest and the pain goes away. What happens is you're using those muscles aren't getting enough blood supply, and that causes pain, just like with a heart attack. It's called claudication, one of the hallmark symptoms of peripheral vascular disease. Some of the other symptoms, numbness in the feet, cold feet, especially at night. And again, it's the same process that causes stroke and causes coronary artery disease. So chances are if you've got this here, you've got it in your carotid artery, you've got it in your coronary arteries. So how do we test for it? This is a pretty standard test across all vascular labs. It's a relatively easy test. It's called an ankle brachial index. And the way we do that is we check the blood pressure in your leg and we compare that to the blood pressure in your arm. If that ratio is over 90%, the chances of you having blockage in your peripheral arteries are real small. So essentially we stop there. Most vascular labs will stop there. So if your percentage is over 90%, then you've essentially got clean peripheral arteries. It's very simple, painless, and again, it's a pretty standard test. This is a picture of it here. We're measuring your blood pressure in your, down near your ankle, and then we measure it up in your arm. Okay, so the same stuff. How do we prevent it? All of these processes essentially are prevented by controlling your fat, exercising, not smoking, controlling your diabetes, hypertension. And then a lot of folks will go on Plavix. You might have heard of some Trentol is another drug that we use for peripheral artery disease. And then if it's bad enough, we do similar things to what we do in the carotid arteries. We do surgery. So we'll do what's called an endarterectomy, where we'll go and clean it out, or we'll do bypass or angioplasty. Angioplasty is where we go in and use a balloon again to blow it up and increase the diameter. And here's a picture of doing a graft. Here is the angioplasty, as I mentioned. There's a balloon that's blown up, and that increases the caliber of blood flow. Okay, the next thing we check for is aneurysm. Anyone know anybody that's ever had aneurysm, abdominal aortic aneurysm? Okay. It can be a devastating problem. A lot of folks that have it don't know they have it. And over 90% mortality if it ruptures on an emergent basis. 18,000 people die a year from this. And if you go and have surgery, there's only a 5% mortality. So especially with abdominal aortic aneurysms, finding these things out before they rupture is the only way to go with this disease. There is still no insurance reimbursement for having a screen for your aorta. Medicare has been working on that element, but right now, if you want to go have your abdominal aorta looked at, you say to your doctor, my father died of a ruptured aneurysm, doc, let me go have a screen on my aorta. I want to make sure I don't have it. I mean, it can be fixed. Well, unfortunately, it's not something you can go have routinely. So that's where we come in. We're able to provide that screening for you. So the biggest thing is to detect the presence of it. And let's say we do your screening and you've got a 2 or 3 centimeter aneurysm. What's going to happen? Typically, a surgeon won't do anything till it's a good 5 or 6 centimeters. So a lot of times we'll find it and then we'll just monitor it on a yearly basis. Make sure your blood pressure is under control. That's probably the most important thing. And then if it enlarges more than 5 centimeters, a lot of times you'll need a repair. This is how we check for it. It's a simple ultrasound on the abdomen. Takes 5 minutes. We're able to visualize that aorta, get some measurements, and we're done. Okay. Another screen that we do is cholesterol. Anyone have their cholesterol checked in the past? Okay. Cholesterol is a fatty substance in the blood that will lead to plaque formation. It's not the entire story, but it's certainly a piece of the puzzle. HDL is the good cholesterol. High-density lipoprotein is what HDL stands for. And we like to see it over 40 in men and over 50 in women. The reason why we like it high is because it actually removes cholesterol from the plaque site. So that's why it's called the good cholesterol. And then it takes the cholesterol back to the liver where it's metabolized. LDL, or low-density lipoprotein, is the bad stuff, and we like to see that under 100 ideally. Triglycerides, which are actual fat globules in your blood, we like to see that less than 150. And how do you, what kind of modifications in your diet? The biggest thing, probably saturated and trans fats. If you can avoid those are probably the most important when it relates to cholesterol. There are 2 places that cholesterol come from in your body. One is your diet, and then the other is your liver, essentially genetic. So you see a lot of these folks that are skinny, they're not eating a whole lot of fat, and their cholesterol's 300. Well, that's genetic. So there are 2 places it comes from. There is definitely adequate treatment out nowadays. Another thing you can do is consume a lot of omega-3 fatty acids. A lot of that in fish, salmon, and omega-3 fatty acids will also decrease your cholesterol. Okay, these are the screens that we perform. Again, for stroke, we do carotid Dopplers. To detect an aneurysm, we do an ultrasound of the aorta. Heart disease, we actually can do an echocardiogram where we look for valvular heart disease, thickening of the heart wall motion problems. Atrial fibrillation, as I mentioned, which is one of the 3 immediate causes of stroke. We do an electrocardiogram, and we would be able to tell whether you're in atrial fibrillation or not. Peripheral vascular disease, blockage in your legs, we do the ankle-brachial index. And then cholesterol profile. So these are the different modalities of screens that we offer. We will be here again on April 2nd providing these. We will be giving you individual instruction, consultation, educational materials. And any questions about any of this? Yes, sir?
Do you have any handouts for that?
For this event?
Or for this kind of screening? I work for wellness screening. I just thought it'd be nice to send out our communications piece.
Sure.
We want to know what type of screening is going to be available and how it works.
Absolutely. In fact, Denise is back here, and she'll be able to also help you with some of the particulars of that event. So, yeah. Any questions about the strokes, aneurysms, cholesterol, disease processes, anything of that nature, or treatments, anything else?
Aneurysm, is that like a blood?
No, an aneurysm, see if I have a picture of it here. Aneurysm is a widening of the aorta. This hash mark here, see the dotted hash marks? That's the normal size of the aorta. And what happens from high blood pressure, from diabetes, smoking, is the wall of the aorta weakens, the muscle wall weakens, and it causes dilatation. So you see it's kind of like a balloon. And that can get bigger and bigger, and just like when you blow up a balloon, too much pressure and it ruptures. So, well, that's a different kind of aneurysm. That's called a Berry aneurysm. That's a specific genetic aneurysm of the carotid artery. The circle is called the circle of Willis, and that's a dilatation of the blood vessel way up in the brain that you have essentially at birth. You have weakening of that vessel wall, And it actually looks like a little berry. It looks like a little blueberry. Instead of being a nice tubular structure, it looks like a blueberry. And that widening can rupture. And that's a completely different animal than this. There's no real modality for screening, per se. I mean, you'd have to have what we call MRA or angiogram, cerebral angiogram for that. But that's a different animal than an aortic abdominal aneurysm. So, any other questions? Yes, sir.
Will you be able to see with the heart scan any type of perfusion of the vessels?
Perfusion of the vessels? Not directly. There's an indirect.
Velocity?
Yes, there are velocities. Yes, we will be able to tell if there are any valvular abnormalities with flow abnormalities, but not specifically the coronary arteries. Coronary arteries are very small, and the resolution of a Doppler ultrasound is not strong enough right now to be able to detect flow characteristics in the coronary artery. We can tell flow characteristics of the valvular structures to tell whether you've got backup of the blood called regurgitation or narrowing called stenosis, but the valves are fairly large. Coronary arteries are pretty small. Ultrasound does not have that kind of resolution. There is a new modality called CT angiogram, which with these very, very high resolution CAT scanners, where they are able to tell some morphology of the coronary arteries, but not with ultrasound. It's just not high enough resolution. But we'll be able to tell indirectly if you've had, for instance, a heart attack in the past, because we'll be able to tell if there's any wall motion problems. If you have a heart attack, that piece of your heart is not beating like the rest of the heart, so we will be able to tell that. Okay, well, listen, thank you very much for coming. Appreciate it, and we will see you on April 2nd. Thank you very much.